I'm conflicted. I think I want to give my patients the best therapy up front because...
So with that as our foundational, where we've been, where we are in a sense, antibody drug conjugates have been all the rage. We've had TDM1 for several years now, but the one that appears to be even more potent and active is trastuzumab deruxtecan. So would you mind just sort of giving us a brief 10,000-foot view of that trial?
Yeah, so we know from the suite of Destiny Breast trials, we know that trastuzumab deruxtecan outperformed TDM1 in the second-line setting. So then we've recently heard at ASCO earlier this year, and then I think was published in the New England Journal of Medicine, the results of Destiny Breast 09. That trial had 3 arms, the traditional Cleopatra regimen arm, T-DXd alone, and T-DXd plus pertuzumab. So what we've heard so far is the T-DXd plus pertuzumab versus the traditional THP arm. And on the T-DXd plus pertuzumab arm, that's the therapy that they received throughout the whole duration of the trial. And we saw a significant improvement in progression-free survival for the patients receiving T-DXd, which I think is what probably most of us expected. And now the question is, how are we going to implement that?
So when you think about that data, which is pretty compelling with a very enhanced time until the disease progresses, are there any patients that you wouldn't give it to?
I'm conflicted. I think I want to give my patients the best therapy up front because I would not at all be surprised if the large improvement we see in progression-free survival translates into an overall survival advantage. And I think we feel that with the use of T-DXd in other settings. So there's this great enthusiasm to do it. I think that you hit the nail on the head earlier about the induction phase, where I'm just a little bit hesitant for these patients who may get great outcomes with this tough upfront induction phase, including taxane, but then a much nicer maintenance phase that may be consistent with their quality of life and day-to-day responsibilities, giving them true cytotoxic therapies indefinitely. And so when I think about which patients am I a little reluctant to do that in, sometimes it comes down just to disease burden. For those patients that might be bone-only lymph node involvement, the hormone-positive patients where we may have some other options to add that we'll talk about. And then also the performance status piece. If there's somebody who I really worry that I could make their quality of life much worse with this drug, am I going to use it now versus save it till later? So it's really a personalized decision for each patient that comes in the door. But I think we have to be honest about where the data is now and where we hope for it to be. And just kind of see where that lands for them.
Yeah, we've always had this idea that, you're not supposed to save the good drugs for later. Right. We tend to use them up front. So do you sort of share the sentiment that you would likely use it more often than not in first-line therapy?
Yeah, I mean, I think in agreement, I'm a little bit conflicted, and I think it will be a patient-by-patient choice because I think I still don't fully know, do you need to get it up front or do you just need to get it at all? And I think making that decision up front will depend on the factors that Dr. Cruz already mentioned. Also, I think I'll think about de novo versus recurrent disease. I'll be much more likely to use the DB09 regimen in people with recurrent disease who received trastuzumab and pertuzumab in the curative setting. So I think that will play in my decision as well. But I think we'll also have to talk to patients about the 2 trials and kind of see what they prefer.
And then they'll say, doctor, what do you think I should do?
What would you do if you were me?
Exactly.
Yes.
Yeah.